Vomiting can be induced by a variety of disease processes, including gastrointestinal, neurologic, renal, psychiatric, cardiovascular, endocrine, pain, and the effects of drugs. The best course of action in identifying the underlying cause is to carry out a detailed clinical evaluation and management plan, looking out for the etiology, consequences, and potential complications of vomiting. Severe uncontrolled vomiting can result in significant dehydration and electrolyte imbalance accompanied by renal complications. Antiemetics should be prescribed only when the cause of vomiting is known, as they may delay diagnosis. Causes: disorders of the gastrointestinal tract and liver, intestinal obstruction, peptic ulcer, pancreatitis, cholecystitis, gastroenteritis, and hepatitis. Neurological disorders: severe pain, migraine, raised intracranial pressure, as tumors, hemorrhage, meningitis, seizures, stroke. Endocrine and metabolic conditions: diabetic ketoacidosis, uremia, hypercalcemia, intestinal pseudoobstruction. Psychiatric conditions like anxiety, depression, severe emotional upset, psychogenic vomiting. Drugs, for example, cancer chemotherapy, aspirin, allopurinol, digoxin, and erythromycin, anticonvulsant, opioids. Infections: malaria, urinary tract infections, cardiovascular causes, acute myocardial infarction among others, renal, uremia from acute or chronic kidney disease, and miscellaneous like pregnancy, cyclical vomiting syndrome, myocardial infarction, labyrinthitis, and otitis media. Symptoms: vomiting may be associated with abdominal pain, diarrhea, gastroenteritis, abdominal distension, suspected bowel obstruction, heartburns, and suspected gastroesophageal reflux disease, chest pain, jaundice in hepatobiliary disease, vertigo, and nystagmus in suspected vestibular neuritis, anxiety, and depression. Vomiting may have diagnostic clues, for example, vomiting of food eaten several hours earlier, as gastroparesis or gastric outlet obstruction, and vomiting with blood in esophageal, gastric, or duodenal lesions. Early morning vomiting, as in pregnancy, and feculent vomiting in intestinal obstruction, gastrocolic fistula, and projectile, as if pyloric stenosis is present. Signs usually elicited are abdominal tenderness, dehydration, as there is reduced skin turgor, dry tongue, hypertension, tachycardia, and also abdominal distension, circumcision splash, jaundice, signs of peritonitis, rebound tenderness, rigidity, guarding, and also miscellaneous, for example, with vertigo, nystagmus, focal neurological signs, and small breathing, as uremia, diabetic ketoacidosis. So investigations are FBC, that's full blood count, B creatinine, LFT, that's liver function test, blood glucose, serum amylase, urine RE, urine pregnancy test, and ECG if myocardial infarction is suspected, and also abdominal x-ray in intestinal obstruction, also erect chest x-ray for bowel perforation with air at the diaphragm. For persistent vomiting, upper gastrointestinal endoscopy is recommended, and serum calcium levels, CT scan of brain. Treatment objectives: to identify and treat the underlying cause, to prevent dehydration and electrolyte imbalance, to maintain nutrition by ensuring adequate dietary intake during illness, to maintain personal hygiene, and also to eliminate infecting organisms where appropriate. Non-pharmacological treatment: maintain adequate oral fluid intake if tolerated, and maintain adequate nutrition. Place nasogastric tube when needed. Surgical intervention in suspected intestinal obstruction and peritonitis. Pharmacological treatment: suggested antiemetics for use in migraine. So you could give metoclopramide oral or IV or IM in adults 10 milligrams 8 hourly, or domperidone oral in adults 10 milligrams 8 hourly. In children aged more than 12 years with body weights greater than or equal to 35 kilograms, you give 10 milligrams 8 to 12 hourly with a maximum dosage of 30 milligrams per day. And 1 month to 12 years with body weights less than or equal to 35 kilograms, you give 250 micrograms per kilogram, 8 to 12 hourly with a maximum dosage of 750 microgram per kilogram per day. Or you give promethazine IV or IM in adults 12.5 to 25 milligrams 6 to 8 hourly as needed, the maximum dosage of 100 milligrams in 24 hours. Or you can give promethazine oral in children 2 to 12 years 0.25 to 1 milligram 6 to 8 hourly as needed with a maximum dosage of 25 milligrams per dosage. And children less than 2 years is not recommended. Suggested antiemetics for use in vestibular nausea and vomiting: can give promethazine oral in adults 20 to 25 milligrams 12 hourly. In children 2 to 12 years, you give 0.25 to 1 milligram 6 to 8 hourly as needed with a maximum dosage 25 milligrams per dosage. And children less than 2 years is not recommended. We could also give promethazine IV or IM adults 12.5 to 25 milligrams 6 to 8 hourly as needed with maximum dosage 100 milligrams in 24 hours. Or can give cyclizine oral in adults 50 milligrams 8 hourly as needed. And in children 6 to 12 years, you give 25 milligrams 8 hourly as needed with a maximum dosage of 75 milligrams in 24 hours. Or you could give cynarizine IV or IM adults and children more than 12 years, you give 30 milligrams 8 hourly as needed. And in children 5 to 12 years, you give 50 milligram 8 15 milligrams 8 hourly as needed, and in children less than 5 years is not recommended. Suggested antiemetics for use in gastroenteritis: can give metoclopramide oral or IV or IM in adults 10 milligrams 8 hourly, or domperidone oral in adults 10 milligrams 8 hourly, and in children of age more than 12 years and body weight greater than or equal to 35 kilograms, give 10 milligrams 8 to 12 hourly with a maximum dosage of 30 milligrams per day, and 1 month to 12 years with body weight less than or equal to 35 kilograms. You give 250 micrograms per kilogram 8 to 12 hourly, the maximum dosage of 750 microgram per kilogram per day. Suggested antiemetics for use in post-operative vomiting: metoclopramide oral or IV or IM in adults, you give 10 milligrams 8 hourly, or you could give cyclizine oral or IV or IM in adults 50 milligrams 8 hourly as needed, and in children 6 to 12 years you give 25 milligrams 8 hourly as needed with a maximum dosage of 75 milligrams in 24 hours. Suggested antiemetics for use in chemotherapy induced vomiting: okay, so you give ondansetron IV in adults 8 milligrams per 0.15 milligrams per kilogram pre-chemotherapy, infused over 15 minutes in children with age more than 6 months. You give 0.15 milligrams per kilogram pre-chemotherapy, infused over 15 minutes, and then repeated 4 and 8 hours after first dose, the maximum dosage of 16 milligrams per dose. So you could also give ondansetron oral in adults 8 milligrams 12 hourly, in children 4 to 12 years. You give 4 milligrams 30 minutes before chemotherapy, and then 4 milligrams 8 hourly for 24 to 48 hours as needed, and less than 4 years, that's in children, is not recommended. Or you could give granisetron IV in adults 1 milligram per 10 microgram per kilogram 30 minutes before chemotherapy, and in children 2 to 16 years is the same as adults, and less than 2 years is not recommended. Or you could give granisetron oral in adults 1 milligram 1 hour before chemotherapy, and then 1 milligram 12 hours after first dose, or 2 milligram 1 hour before chemotherapy. In children is not recommended. Or you could give dexamethasone oral or IV in adults 8 to 12 milligrams before chemotherapy, and then 8 milligrams 24 hourly from days 2 to 4. In children it's not recommended. Or you could also give lorazepam oral or IV in adults 0.5 to 2 milligrams 6 hourly as required. For children, consult a specialist. Suggested antiemetics for use in pregnancy: so in pregnancy you give promethazine thioclate oral 10 to 20 milligrams 8 hourly as needed, or promethazine IM 12.5 to 25 milligrams 8 hourly as needed, or metoclopramide oral, that's 10 milligrams 8 hourly, or metoclopramide IV or IM 10 milligrams 8 hourly as needed. Referral criteria: refer all patients in whom vomiting persists or who show signs of progression in disease, patients with unexplained or persistent vomiting, and patients with suspected surgical cause of vomiting for specialist or surgical assessment and management.